Hello, this chapter is going to talk about inpatient prospective payment systems, which is what CMS uses for reimbursement for Medicare and Medicaid. They established this system in the early 1980s to try to motivate doctors to treat patients more cost effectively. There are separate PPS, prospective payment systems, used for outpatient hospital services, skilled nursing facilities, home health, inpatient rehab, hospice, long-term care, inpatient psych facilities. Okay, so we're going to touch on those a little bit, but we'll go over those more next week. This week, we're going to focus on inpatient PPSs. There are a variety of inpatient settings, and each setting uses a different PPS. For acute inpatient hospitals, okay, before I go on, actually, because there are so many different PPSs, and each one uses a different tool to determine reimbursement, I think it would really benefit you to make a little chart as I'm going through each of these. So like write down the setting type, acute inpatient hospital, and then what PPS is used, inpatient prospective payment system or IPPS, and then what they base reimbursement on, DRGs. Okay, that way you have it all listed right there, and it'll make it a little less confusing because I'm going to go over like 6 or 7 different ones. So anyways, acute inpatient hospitals use the inpatient prospective payment system or IPPS, and it's based on diagnosis-related groups or DRGs. If you're in medical coding, you're going to learn all about DRGs, but these group patients that have similar diagnoses and treatments, similar ages, similar length of stays together in one category. And then each DRG category is assigned a payment weight based on like the average amount of resources that are used for people with that diagnosis. So the reimbursement is based on this weight, okay? The PPS for inpatient rehabilitation facilities uses the case mix group or CMG system. For this one, each patient is assessed using the inpatient rehabilitation facilities patient assessment instrument or IRF-PI. The IRF-PI classifies patients into groups also, but they're based on clinical characteristics and what expected resource needs are going to be. So the case mix group determines the payment rate per stay for inpatient rehab facilities. For an inpatient psychiatric facility or IPF, the PPS is based on a per diem rate, so a set rate per day. But adjustments can be made if the patient's treatment is significantly more expensive. This system is set up to give like a higher per diem rate for the first few days of stay because that's usually when the most intensive treatment is going to be, those first couple days they're in the facility. The PPS for long-term care hospitals is a per discharge system with an MSDRG patient classification system that's very similar to the IPPS system we talked about on the last slide. The outpatient hospital PPS, OPPS, includes hospital-based clinics like ERs, observations, and ambulatory surgery. So these use the ambulatory payment classification system or APC. Payment rates for this are based on categories of services that are similar in cost and that use similar amounts of resources. And I know I keep saying that things are grouped together based on similarities, but to give you an example of that, like a chest x-ray would be grouped with an x-ray of your arm, whereas a swab to check for the flu would not be grouped with that, right? It's a completely different type of service that doesn't require nearly the amount of time or the skill level by the person administering it, or as expensive equipment to use. Okay, so it's a good bit cheaper to do a swab with basically like a Q-tip than doing an x-ray. So the reimbursement groups are going to be completely different. Okay. In skilled nursing facilities, the PPS used is resource utilization groups, or RUGs. The patient is assessed using the minimum data set, MDS. This is a clinical assessment done by a nurse to see what the patient's needs are, what are their functional capabilities, what can they do by themselves. So based on the MDS, the patient is placed into a RUG, which determines the facility's reimbursement rate. For home health agencies, the PPS is the Home Health Resource Group, or HHRG. The Outcome Assessment Information Set, or OASIS, is the assessment tool that they use to determine the HHRG. The HHRG will give this predetermined base payment rate for each 30-day episode of care. Okay, then they'd have to be like reevaluated after 30 days. And then hospice is paid on a per diem rate for each level of care. So like routine home care versus continuous home care, inpatient respite care versus general inpatient care, things like that. Okay, so like I mentioned before, PPSs were created to try to motivate doctors to treat patients more cost effectively, because before they used these, they were reimbursed based on the cost of services and reasonable costs. So there was really no incentive for the doctor or the hospital to sort of, be smart with how they were treating patients. They didn't care if they were using extra resources that may not be necessary, right? They would just bill for it and get paid. So the payments that CMS was making for these Medicare patients were rising, getting higher and higher, to the point where they were concerned about the Medicare trust fund running out and not being able to pay for Medicare patients' treatments anymore. Because, well, let me take a step back. So when you get a paycheck and see the money that's taken out that goes to federal and state income tax, those income taxes are what pay for Medicare and Medicaid. So it's not this endless bucket of money, right? So in the 1970s, they were worried about that money running out. If the payments were to continue the way they had been, it eventually would have. So they came up with this idea of PPSs so that doctors and hospitals would treat patients more cost effectively. Like I said, it wasn't so, patients couldn't receive all the treatments they needed. It was just so that doctors weren't using more than they needed. Okay, there are 4 guiding principles under PPSs. Payment rates are to be established in advance and fixed for the fiscal period to which they apply. Payment rates are not automatically determined by the hospital's past or current actual cost. Prospective payment rates are payment in full, and the hospital retains the profit or suffers the loss resulting from the difference between the payment rate and the hospital's cost, which that's what creates that incentive for cost control. Okay. So the inpatient IPPS was the first one that was introduced. The base rate is divided into labor-related and non-labor-related shares. The labor-related share is adjusted by the wage index that relates to the physical location where the hospital is located. Remember we talked about, cost of living being cheaper here than in California. So that takes that into consideration. Then the base payment rate is multiplied by the DRG relative weight, or RW. So the relative weight measures how resource intense a patient is within their DRG group. Someone that, has the same diagnosis, but they require more treatment or more resources. So they're going to have a higher weight because it'll cost more money to treat them. They can make adjustments to the payments if the hospital encounters any obstacles, such as if the hospital treats a high percentage of patients with low incomes, then they can receive a percentage add-on payment applied to the DRG adjusted base payment rate. This specific add-on rate is known as the disproportionate share hospital adjustment. But they have others. So like if the hospital's an approved teaching hospital, it gets a medical education adjustment. And there's a few others. Okay. A patient can only have one DRG assigned and reimbursed for per hospital stay. It could change for that person for the next hospital stay. Like it doesn't have to be the same DRG every time. It probably typically is for patients with like chronic diseases. But every service done during that stay is included in this single DRG payment, all the tests, medications, supplies, etc. The structure of the DRG system is a hierarchy and begins with major diagnostic categories, or MDCs. Each MDC is based on a major body system, so the nervous system, the respiratory system, circulatory system, etc. There's 25 of these categories. The conditions in these categories are identified by ICD-10-CM diagnosis codes. So each MDC is separated into medical or surgical categories based on if the patient had a procedure done or not. And that's where the hierarchy comes in. You have the category at the top split into medical with all those conditions listed, surgical with all those procedures listed. Okay. There are several variables that affect the assignment of DRGs within the MDCs. I know it's a lot of abbreviations, but the medical field is full of them, so just get used to it now. Principal diagnosis. So this is the main reason the patient is in the hospital. What's the cause for this need of treatment? The secondary diagnosis is all of the other conditions that the patient has when they're admitted, or that they develop that, while they're there, and that affect what treatment they get or how long they stay in the hospital. To be listed as a secondary diagnosis, it has to meet certain criteria, like this condition requires clinical evaluation, it requires therapeutic treatment or diagnostic procedures, it increases the length of stay, and how much care the nurse has to give. We're going to talk about CCs and MCCs in a minute. It's related to secondary diagnosis. What's the principal or significant procedure, the big procedure done? And then age, sex, and discharge status, they also have an effect on DRG assignment. Typically, an older age group will require more resources than a younger one. So the DRG is split according to age. Okay. In 2008, the DRG system was adjusted to take the severity of an illness into account. So this is the third level in the DRG hierarchy, designating, the surgical or medical, and then the severity DRGs. Okay, the Medicare Severity Diagnosis Related Groups, MSDRGs, okay? So CMS can pay hospitals that treat severely ill patients higher amounts. So let's see. I have an example. Well, I don't have my textbook with me, but there is an example in the textbook or in your ebook of a partial list of ICD-10-CM codes and diagnoses in an MSDRG grouping. So you can look at that to see, like the title of the group. I think it was uncomplicated peptic ulcer. And then it'll have, the relative weight, which is, remember, how many resources are used. It has like the geometric length of stay, GMLOS. That's the national average length of stay that the CMS publishes. And then the arithmetic mean length of stay is the average length of stay by people that are in this particular DRG. And then it'll have like all the ICD-10 CM codes that are included in that one. Well, I think it's just an example of some of them. Okay, the severity of illness just shows or just allows them to get more specific so that CMS can reimburse more complex cases enough money. There's 3 levels, and this is assigned based on complications and comorbidity, or CC conditions. So a complication is something that happens after admission, and comorbidities are conditions that already exist, like prior to being admitted to the hospital, like high blood pressure or, diabetes, things like that. CCs are secondary conditions, not the principal diagnosis, that have a moderate impact on resource use. So because of the presence of this condition with the principal diagnosis, there is a 1-day increase in length of stay in at least 75% of patients with that same principal diagnosis. So without that CC, they would not have that extra day. Okay, then we have major CCs or MCCs. These are just secondary conditions that have a major impact on resource use. And then non-CCs or MCCs. These are secondary conditions that have just a minor severity of illness and don't really impact resource use. Okay, so CCs can increase the severity level. MSDRG families are groups of MSDRGs that have the same base set of principal diagnoses, with or without operating room procedures, but they're divided into levels to represent the severity of the illness. Okay, we've talked about relative weights a couple of times. This measures the resource intensity, how much is used to treat a patient. Every DRG is assigned a relative weight, and each DRG also has a payment rate assigned to it based on the average resources used to treat a Medicare patient in that DRG. So the relative weight is what kind of personalizes it to each patient. The case mix index is a weighted average of the total of the relative weights of all patients treated during a specific time. So this is really looked at by like hospital administration, so they can see how much is used per year or in a certain time frame. Doctors also look at this as well to tell them, like how severe the illnesses they're treating were or how difficult to treat were they. Oops, wrong way. Okay. Now, how is the actual payment calculated? The DRGs are the same payment-wise for every facility, but some hospitals, like the payment amount, but some hospitals can receive those add-on payments that I mentioned earlier, like the disproportionate share, medical education, sites, etc. So each facility is assigned a base rate that takes these add-ons and other factors into account. And so then it's called the adjusted base rate. So the hospital's adjusted base rate is multiplied by the DRG relative weight to determine what the actual payment for the facility is. And that's the formula right there, the third bullet point. So hospitals can use this formula to try to calculate what they can expect to be paid for each patient admission. You don't need to know how to manually calculate it for my class, but that is the formula. Okay, I already mentioned some of these things that qualify the hospital for additional payments or add-on payments. The disproportionate share is hospitals that serve mostly low-income patients, because a lot of times those patients can't pay their bills, and so this helps the hospital remain whole. Indirect medical education adjustments for teaching hospitals where doctors are still training and work under a teaching physician. High cost outlier admission covers like extreme cases that have really high costs compared to most cases under that same DRG. And new medical services and technology adjustments. This is for facilities that provide like innovative services and use newer technologies, because the cost of the new technology or service is usually more expensive, and it may not be accounted for in the DRG. Okay. There are other CMS rules that can impact IPPS payments. So revenue cycle managers have to be aware of these as well. Okay, the inpatient admissions rule says that only doctors or licensed practitioners can admit a patient to the hospital. Sometimes after admission, the utilization review process shows that the patient shouldn't be an inpatient, so they can change them to their status to outpatient. When they do this, they have to report condition code 44, which is that third bullet point, on the outpatient claim. The 2 midnight rule is for when the doctor thinks the patient will need less than 2 midnights of hospital care. This can be payable under Medicare Part A on a case-by-case basis. The doctor has to document that, an inpatient admission is necessary and explain why. All right, condition code 44, like I mentioned before, when a patient's initially admitted as an inpatient and then changed to outpatient status. There's 4 qualifying factors for this. The change has to be made before they're discharged and before the hospital has billed Medicare. The doctor has to agree that they can be changed to outpatient, like agree with the utilization review people, and then it has to be documented in the record. Okay. The 3-day payment rule bundles all of the outpatient services that a patient has within 3 days before being admitted to the hospital. So any like lab work or x-rays, etc., that all goes into the one DRG payment for the patient together with the admission. Okay, it's not billed separately. And then the transfer rule is for when a patient is transferred somewhere else before all of their treatment or care is completed. So if they transfer from one acute inpatient hospital to another acute inpatient hospital, the 2 facilities will actually share the DRG total payment. If they go to a skilled nursing facility instead, then the hospital will get a % of the full payment plus the per diem amount. And the reason they do this is so that hospitals don't transfer patients early to like cut costs, save money, and then still receive the full payment. Okay, so they don't get the full payment if they're transferred early. Okay, specialty hospitals were not included in the IPPS when it first came out, so Medicare now pays for these with their own specific prospective payment systems, like I mentioned earlier. Okay, we're going to go through each of these. Inpatient rehabilitation facility prospective payment system, or IRF PPS, is used for rehab hospitals, which is where patients that are recovering from like a serious illness or surgery can go when they need very specialized care that can't be given in a different setting. For things like the examples here, so someone recovering from a stroke or a spinal cord or brain injury. Okay. IRFs have to meet the reasonable and necessary IRF service and coverage requirements to qualify for payments under the IRF PPS. So some of these requirements are, and you don't need to remember these, a licensed clinician has to do a pre-admission screening within 48 hours of admission, which is very detailed. They have to discuss the patient in weekly meetings with the doctor, the nurse, social worker, therapist. The patient has to need therapy from multiple disciplines like physical therapy, occupational, respiratory therapy. And they have to have that therapy at least 3 hours a day, 5 days a week. And be showing improvement. And there's a couple others, but you can tell from these that these are major requirements, right? This is not just for someone that needs a little help. This is serious therapeutic treatment. Payment for these are on a per discharge basis. Patients are grouped based on their clinical conditions and like what their expected resource needs are going to be. Okay, the Inpatient Psychiatric Facility Prospective Payment System, or IRF IPF PPS, excuse me, is used for psych hospitals and psych units in acute care or critical access hospitals. So this is for Medicare beneficiaries that have serious mental illnesses or alcohol or drug related problems. The IPF PPS uses predetermined rates based on diagnosis, comorbidities, age, length of stay, and location of the facility. They have to establish medical necessity on admission. Like, could this patient be treated somewhere outpatient, or do they need to be inpatient for this? And then reevaluated on the 18th day of after admission. So the payment will cover all routine, ancillary, and capital costs, with, again, a higher payment for the first few days of stay, because those are usually more care intensive. If someone is discharged and readmitted within 3 days, either back to the same facility or to a different psych facility, it is considered one continuous stay under the interrupted stay provision for payment purposes. Okay, interrupted stay provision. So, because obviously, if the person has to be readmitted again or admitted again, they probably shouldn't have been discharged in the first place. All right. Long-term care hospitals use the Long-Term Care Hospital Prospective Payment System, LTCH PPS. These facilities treat, like medically complex patients that need a longer hospital stay than they would get at like an acute care hospital. On average, the length of stay has to be longer than 25 days, okay? A lot of patients that get transferred here are coming from an intensive or critical care unit, and are being treated for more than one serious condition, but will hopefully recover and go back home. They can provide respiratory therapy, head trauma treatment, pain management, among other things. Payments are made at a predetermined per discharge amount. They use MSLTC DRGs, which are basically the same as MSDRGs, but just more specific to long-term care facilities, just to account for the different resources. Okay. Last slide. Third-party payers, like commercial health plans, right? Not Medicare, adopted the all patient diagnosis related groups, APR-DRG, to use for their reimbursement. And it works very similarly to the Medicare ones, payments based on severity of illness, risk of mortality, etc. The APR-DRG has 314 base DRGs with 4 severity subgroups in each DRG: minor, moderate, major, or extreme. Okay? And that's it. I hope y'all have a great week, and thank you.